I can start with one case.
All right.
All right. And I'm recording, so we're good.
All right, thanks.
So it says, go to meeting, would like to capture this computer screen. I have to open preferences for that. Wow.
Must have updated your operating system recently.
I did. Until it is quit. I have to quit and then come back. So that's it. That's it for me for a while.
Jeff, you want me to? I can go ahead and go.
Okay.
Or Seth, if you want to, go for it.
Yeah, I mean, I can go and show.
All right. Let's see. How's that?
How do I move that? 1 second. Okay. So this is more of a differential diagnosis case. Guy's got his whole. Is this the case? Oh no, this is a different case. This is actually quite interesting. And I don't know if I've seen this with path on both sides. So here's a patient that has a pattern of fibrosis. You can see there's surgical biopsy material here. I don't know what I don't know what people call it. I mean, I would say this is pretty darn typical for NSIP. And the patient had a biopsy, and sure enough, it was read out as NSIP. This is 2013. Now here's the patient. So he's diagnosed with mixed connective tissue disease, and here's the patient now 4 years later. And with what I think anyone here would probably call, well, again, this is where it gets confusing because this is not IPF, but it is UIP pathologically. It's UIP pathologically, because it looks like UIP pathologically, or at least on imaging. And then also he had an explant, which both explants showed UIP. With this whole naming thing, we would say, maybe people would say, well, given the amount of ground glass, it's, inconsistent with UIP. And that's what drives me nuts about the whole thing, because it is UIP. Anyways, I don't think I've seen a case of such profound transformation from a NSIP pattern that's been path proven to a UIP pattern that's been path proven. I don't know what other people think, if they've seen that. I mean, I have cases where I don't have path proof, and I can say, well, maybe it was UIP the whole time. But the patient wound up having mixed connective tissue disease, so that was the underlying cause of the injury. But I just thought a really striking transformation.
I've seen this. It doesn't surprise me. I think the UIP is not a disease. It's a
yeah.
So you can get to UIP from NSIP in autoimmune diseases. It just takes longer than it does to get there with IPF, which may present with a UIP pattern. But seen a lot of NSIP slowly turn into UIP pattern. And,
with path on both sides showing it, because I have cases that I thought were NSIP, and they undergo biopsy, and the path comes back as UIP. And again, the connection between the two is, well, it's questionable. But anyways, I don't think I've seen a path case where with a biopsy and an explant. But anyways.
Well, we probably wouldn't biopsy that today. I mean, maybe 10 years ago they did, but I mean, people with CTD.
The NSIP one? Or
yeah, I don't think we would have biopsied that. I mean, especially if you have a CTD now. I mean,
yeah.
And plus, as patients get referred to more centers. There was an old paper from the University of British Columbia.
Yeah, Mueller and what's her name?
Silva.
Yeah, Silva. Yeah, that one.
Yeah, where they showed that over time, they followed some NSIP people, some up like 15 years out, and they showed that at least on imaging, it
exactly
looked more like UIP, and we know a UIP pattern has a strong correlation with histology. So, it's just probably an evolution of the insult. And
Yeah.
maybe
No, and I do have cases. I just never had one with a
No,
biopsy.
no,
And
it's nice to have that. I've seen them on imaging where they've gone from what looks like I'd call NSIP to what I would call UIP. And that's one of the things I've been stressing lately to my trainees and in our ILD conferences. When we have a case, I want all the old imaging, because sometimes what it looks like UIP now, but you realize, first of all, it's progressing over a decade, not 2 years.
Yeah.
And it really hints at CTD as the underlying cause when you see what looks more like NSIP at the beginning.
yes,
Not that
absolutely.
it matters when you're that far along nearly as much, but if you have an undiagnosed CTD, you still may end up treating that differently than just run-of-the-mill IPF. But it's so cool you have the path on it. And
Yeah, it's a shame, and I agree with you. The worst thing is that no one's getting PATH anymore. It's just except on explant, because if it looks like NSIP, we'll treat them with some sort of immune modulating drug, and if it looks like IPF, we'll treat them with antifibrotics, and that's it.
That's it, yeah.
Jeff's point's really important, that the best imaging for interstitial is the earliest imaging.
Yeah. No, and you always have to go back, and that's what's great about PACS now. I mean, this was you can see this case is now, the initial one was from 2013. I mean, this was just a post-lung transplant x-ray I was following up. And of course, I always go to the first study. I said, oh, it looks like NSIP. And then I pulled up the next CT, which we had, which was just 2017. I was like, oh, look at that. And then looked at his biopsy results and then his explant results, and it was pretty nice. And then I always harp about this, where you have a case where, of course, the one on the right is going to be UIP, but with the new terminology, we have to say findings inconsistent with UIP because of the amount of ground glass, and this is clearly due to connective tissue disease. But at the same time, it is UIP. I just run circles around in my mind on it.
Yeah, for these cases now, I just don't even designate. I just say in keeping with their known connective tissue disease. Right.
Oh yeah. See, I would say, IPF, or sorry, I would say UIP pattern due to connective tissue disease. But yeah. Anyways,
it's a semantic thing, but we all seem to be imprisoned by it, enthralled by it.
Yeah.
And Seth, you may have seen this too, but Jeff Galvin and your folks at Maryland had a recent piece on fibrosis and like the idiopathic interstitial pneumonias and how most of them aren't idiopathic, and also like making a distinction between those that are progressive and those that don't progress, which I think is as important as anything at this point.
Yeah.
It's like, is it getting worse or not? Just to drive management.
Let me just. This is not the most interesting case. This is the differential with this little nugget in the anterior mediastinum, and then on delayed imaging, arterial phase imaging, very avidly enhancing, and thought to be a paraganglioma, which is a good guess. There's some feeding vessels coming out of it, actually more draining veins. But anyways, this has a differential. I mean, it could be a very large parathyroid adenoma. Could be a thymoma, given the patient was in her 50s or 60s, just an avidly enhancing one. Then you get into the weird ones like Castleman disease and hemangioma, and this was taken out. This was just a hemangioma, so an anterior mediastinal hemangioma.
What was the attenuation on non-con? I mean, this is big, certainly bigger than one that you just blow off as a node or some sort of.
No, it's big. I mean, it's 47.
Yeah.
And
nice case.
It's two. I mean, this thing is a couple centimeters, so 3 by 2.5. So pretty big. What was this case? Oh, this is just a follow-up. Let me see if I can do this real quick. So I showed this a couple months ago. Travis wasn't here. He showed one the week before. And I said, and just happened to be that week we saw one in CTEF conference. Anyway, so they took it out And I don't know which one is which. Let's see. So that's the sausage. You know, the sausage from the sausage sign. That really does look like a bratwurst. I mean, I don't know
It
what other
really is the
people
mirror
think.
image because mine is on the right side.
That's a Wisconsin.
Yeah, I mean that. There's the casing. There's the sheep gut casing. Anyways, and then here is the path, and you could see, because we talked about that, it probably had osteosarcomatous elements, and here it is with the osteosarcomatous elements and chondrosarcomatous elements too in this. So, can you guys still hear me?
Yes.
Oh,
Yes.
okay. So anyways, the path shows that, because we were wondering, it's like, oh, it has to be some sort of osteosarcoma, but it's osteosarcoma and chondrosarcoma within this very differentiated sarcoma. So it was nice to see the path showing what we assumed on imaging. And then this was a case we had the other day where patient comes in with chest pain and a very nice, beautiful example of a SCAD. So you can see this is a long segment lesion with here's the lumen, and then you can see here's the thrombosed false lumen, or I don't know if you think it's people think it's a dissection or truly a rupture of the vasovasorum. It could be an intramural hematoma or a thrombosed false lumen. So here it is, and then it goes all the way down. You can see it all the way around. It's also around the diagonal here, and then around the LAD as well. And the distal LAD gets just hammered from it. So, and then the cath images were, they're okay. I mean, honestly, I'm not the best at cath images, but you can see the abrupt transformation of the LAD here, and then it kind of peters out. And then same on this other view, where you can see there's just this abrupt transformation, and then the vessel just gets kind of squished all the way down. So we've seen a bunch of SCADs this year. I don't know, honestly, I think it's just, they're not that uncommon. I think we're just I mean, this one's very, very classic, but I think we're just recognizing them more. And, you know, a lot of cases, this one's so diffuse, but a lot of cases that we might have called something else, you know, 10 years ago, we're realizing how, especially in women, how common SCADs really is. So
So are you
do you
doing
think,
a lot? Oh, sorry, Jeff, go ahead.
oh, I was going to say, do you think in the past more of them went straight to the cath lab, and now that we do more coronary CT in them setting, that because they're younger, they send them to CT first?
you do make a very, very good point. I also think it's institution. So you're right. The reason we see a lot of SCAD here is we're doing a lot more imaging on these patients who theoretically should have gone straight to the cath lab. So someone with a troponin bump, you know, typical symptoms, troponin bump, that's a younger patient, even an older patient, man, it's amazing that people are doing coronaries on that should go right to the cath lab. But in these cases, it's not a bad idea to take them to the cath lab. This patient was actually the reverse. This was a cath lab finding. So she did go right to cath, and then after the cath, before discharge, they wanted to image her. I think that was the story. But we have other ones where they go straight to us and then go for the cath after, then don't go to cath because you don't really want to stick a wire down these. But you're right. I mean, I don't think we saw a ton at Maryland, because if anyone had a troponin bump, they went right to the cath lab, and then they didn't do a lot of post imaging to follow it up. But I saw another one yesterday that was a very focal, again, the whole discussion of a type 3 SCAD, or someone called a very focal SCAD, and that's what she's labeled as. But we're doing a lot of imaging to follow these up over time as well, which I don't remember doing in the past either. But yes, I think we're imaging a lot more of them early on. All right, those are my cases.
All right, thanks, Seth. Travis, did you want to go? Or David, are you ready, up and running?
I hope I'm ready. Can people see an abnormal chest graph?
Yep.
So I encountered this patient yesterday with this mediastinal enlargement here, which seems to go pretty far high. It goes way high above the clavicle, meaning it must have a posterior component. And so there's also kind of a drain flitting around here. Here is what's going on in this person. This is a mediastinal abscess, but the mediastinal abscess that contains some gas is way extensive, goes way up into the neck. And let me show you on this neck CT. Can you see this neck CT on split screen, guys?
Yeah.
Okay. So here it is going way up into the neck, and it arises from the site of extraction of a lower molar here on the in the jaw. So this person had extraction on September the 2nd because of an abscess tooth back here, and was given some antibiotics, which he said he took religiously afterwards, and then noticed some facial swelling, went to the ER, and has this extensive abscess throughout the neck, coming down, and chest wall here, neck wall, and chest wall, and then coming down into the mediastinum as well. And some organisms have been identified, some gram-positive cocci, but we don't have culture results yet to speciate, but it's probably going to be staph, maybe strep. So big abscess from an infected tooth extending down into the mediastinum. So this shows the importance of regular flossing. So I hope we all get out our floss, guys, and right after lunch, let's go brush and floss. Are we still connected?
Yeah, that's impressive, David. So what was the time frame between when he had the extraction and when he showed up for care?
He had the extraction on the 2nd of September, and then I don't know when he went to his local facilities. He was from Pasco, Washington. He arrived here on the 14th, and then had some neck exploration and some drainage. So starting yesterday.
Okay, I'm just curious how long. I mean, you mentioned the facial swelling, but you think he would have been pretty toxic?
He noticed the swelling, but he didn't seem to be that extreme, and his white count is a mere 8.7. It's not huge. I would have thought it would have been in 20,000 range and stuff like that. Okay.
Wow.
You want to go now, Travis?
Sure. That was it, David? That was.
No, that's it.
All right. Not implying that wasn't impressive enough, because it was. All right. So I've got a few cases here. A couple of these are older ones that Paige was going through some of his old stuff and showing me, and figured I'd have to share. So this is I think this lady is in her 30s, maybe younger than that, 43 at this time. And you can see she presented with a spontaneous pneumothorax, and when you look, her lungs are diffusely abnormal, way too white, and maybe you can tease out there's some nodules there. She had several CTs. You'll note there's some subcutaneous gas here, and I don't know exactly when this was taken, but it's because the chest tube ended up outside of the lung and outside of the pleural space in the back. But this is a thicker slices, but just crazy, the number of nodules just diffusely involving her lungs. And there's so many, you'd say probably that they're random in distribution. I think, even though it's interesting, there seems to, I don't know if this is a little bit of just paraseptal emphysema or paracicitricial emphysema along the subpleural spaces, or fibrosis, just because of the extent of everything else in her lungs. But that was one CT. This was actually a little bit after she started a specific treatment. and you can see that things have improved some, and her symptoms dramatically improved. So any guesses on what this is?
Is this just disseminated TB?
Yeah, well,
Or
right. I was wondering if this was some sort of granulomatous infection. She was, she was dyspneic, but she wasn't actin infected, didn't have B symptoms. I first looked at the thyroid to see if this could just be crazy, like papillary thyroid cancer.
is this a weak sarcoid?
Well, that was the other thing I thought too. No, this she had a hysterectomy for fibroids. They did a transbronchial biopsy, and this was all benign metastasizing leiomyomas.
Oh my goodness.
Yeah, they put her on rituximab and some other chemotherapeutic agent, and she responded and symptomatically got much better. And this was 10 years ago, and she's still alive. She hasn't even had imaging here in the last few years.
Did they just like shred the uterus and just put it into her IVC? I mean, like,
No idea. No idea. But it's interesting. I showed this to Sanjeev and Costa, and they had a case at Mallinckrodt not too dissimilar from this. Now, I have no idea if it's the same patient that happened to have gone to another institution too, but they had seen one that was this disseminated. So yeah,
What did you?
I mean,
What was the therapy that they gave?
I believe it was rituximab and some other chemotherapeutic agent. It's so old that like the notes didn't even migrate in the electronic medical record. This is, it's not so old, but it was old enough where they didn't migrate. It was 10 years ago. So, all right. So David, this one's for you. This is a patient in their 60s who is a physician or was a physician, and you can see got a CT PE protocol, has profound enlargement of their right ventricle, right atrium, little interatrial septal deviation to the left. And it's interesting too how small their left atrium is and how small their pulmonary veins are. So some serious right-sided heart failure going on here, contrast blood level in the right atrium. No PE, no macroscopic PE, and I will show you the lungs because you may suspect where this is going, but there's absolutely nothing that I see in her lung parenchyma. She ended up passing away shortly after this exam. And David, what did the autopsy show that we can't see on CT here?
The effects of injecting drugs.
Yep. And she had a couple of indwelling catheters. And yeah, so it was excipient lung. And, I don't know. I don't see anything here in the lungs, but it makes the most sense, for an acute right heart failure like this. I looked to see if there was, if the right coronary artery was knocked out. It's not. But yeah, and I don't know if and she had the catheter in her at this time too, but that radiograph was from just before this. So
Travis, do we know what, it may depend on what sort of tablet she was injecting, what the excipient was.
Yeah, so the autopsy report said that it was some cellulose and methyl cellulose. So I don't know what the tablets were at that time. We haven't seen much. I haven't seen a case in a couple of years. I don't know if any of you watched or have read any of the books or watched the documentaries on the Sackler family and OxyContin and how it's been reformulated in the last few years. But I know that was one of the most popular ones being injected. I don't know if some of the change in formulation has led to a reduction in cases. That really hasn't been, I'm just speculating. I mean, we haven't seen it in a couple of years. I don't know if you guys have seen a recent case. This one's 4 or 5 years old.
That's a good point. I don't think I've seen it that much lately. So I like your idea of reformulating. If they just change the excipient, it may change the intensity of the granulomatous response and our ability to see, the little central lobular nodules or not. So
And
might have plugged them up but not had the intense granulomatous reaction that makes the vessels bigger and sort of visible.
And my understanding too is part of the reason for the reformulation was to reduce the effect and the ability to inject, OxyContin at least.
Uh-huh.
So I don't know. I don't pretend to be an expert in the effects of injecting, just the pulmonary manifestations of it. So, but I was when I was watching that, I was thinking about, and there was a really good book recently that I read on the Purdue Pharma, and that kind of got into some of that. But I don't know the chemical details of it, but I was just thinking that I haven't seen much lately. All right, this next one, let me make sure, let's see if we're going in the, I think this is the, yeah. So this is a patient who, let's see, no, that's the old case. This is pre-heart transplant. So dilated, it was an ischemic cardiomyopathy. This patient got a heart transplant, that's last year. And then this is, let's see, make sure I've got the right one. Yeah, so this was back in earlier this year. And there's a couple little nodular areas of consolidation, a little surrounding ground glass halo. And then there was this area here, and this patient had low-grade fevers, respiratory symptoms. And, this looks awfully suspicious for fungal infection. Almost, it looks like you've got a little infarct developing here, with the halo, the consolidation, a little bit of a reverse halo. So kind of the combo of both. And this patient was on broad spectrum antibiotics and antifungals. And a week later, got this CT, as clinically they weren't doing much better. You can see a little area here. The area in the right upper lobe actually improved. I think this is the remnant of that. But this area, looks like mucor, looks like a big area of infarction. I'm guessing people would agree with that. You kind of got the halo and the reverse halo, and the looks a little bit like a bird's nest, big rind of consolidation here. And they ended up doing a lobectomy, and it was in fact mucor. This was angioinvasive mucor. So I think this is the first time I've seen one in a non-neutropenic patient. This is a patient on steroids, has diabetes as well, also immunosuppressed, other immunosuppressive agents from their heart transplant. But certainly it's, diabetes being one of the more common, non-neutropenic conditions where patients get mucor, but this is the first one I had seen.
Yeah. So, remember there was that phase of the COVID pandemic that first summer where the Delta variant took off in India, and there were lots of patients dying of mucor because they were diabetic going into the hospital, and then they were put on steroids, and that combination, the steroids helped them get through the COVID, but it predisposed them along with the diabetes, and so a number of people died with a combination of COVID and mucor. So I think this setting of diabetes and then put somebody on steroids, that does open them up to mucor.
Yeah, just typical evolution. I mean, it looks very similar to what we would see in a neutropenic patient.
Right.
So.
The thing about mucor is it's often out against the edges of the lung like this. It likes the edge, sometimes it's way up at the top of the lung, but often near the axilla or in the base like this, near the external pleural surfaces. So it does that more often than aspergillus. Aspergillus seems to like the centers of lungs, and mucor often chooses the more peripheral lesions, sort of the embolic location, where you'd expect to see pulmonary embolism or septic emboli sort of thing.
And then this is one of those ones that belongs on the FBI most wanted list, like the have you seen this look before? This is from a couple months ago. And, let me see if I can window it, but you'll see scrolling through here that I'm curious if anyone has thoughts on this, because Paige showed this to me. He found one case report that I can discuss in a minute. He asked me if I had seen anything like this before, but you can see it's not the airways, but it is along the airways. And this is a woman in her 40s who's profoundly dyspneic and is actually being considered for lung transplant because her symptoms aren't improving, but just radiating out along all of the bronchovascular bundles, just get these areas of what looks like emphysema, adjacent to the airways. And I can't remember, David, if you or Howard showed something that looked kind of like this and ended up being amyloid. That was the one thing I thought maybe, there's some other clinical history I can give you guys in a minute. I'm just curious if anybody has seen this look before.
No, I've not.
Jeff or Seth or anybody else? I mean, it's bizarre.
Yeah.
Is it some other protein deposition?
Well, we don't
besides amyloid?
know. I mean, we don't know yet. I don't think they've done any sort of.
I would have also, I'm not the typical, but I'd also wonder about alpha-1 because sometimes it does some.
And so her history, this is to complicate things. That's a really good thought. So she does have an alpha-1 mutation. It's not the typical mutation, but she does have some alpha-1 mutation. She also has Sjogren's syndrome, which made me, again, wonder, could she have some amyloid in here? But, this is going to be on my list for if and when she does get a lung transplant, just to figure out what the heck this is. But yeah, Jeff, I think your thought about alpha-1 is a really good one. And now
I've seen a few cases of alpha-1 that didn't have emphysema, but had just profound bronchiectasis.
Yeah, I'm going to stop.
Just spectrum somewhere.
Yeah, give me 1 second. I stopped so I can pull up this case report that Paige had sent me. There was one case of it being called pulmonary interstitial emphysema. That's what this one paper had ended up calling it, which I don't know. Let's see. Here, I can stop. Give me 1 sec. I've got here. Yeah, it's persistent diffuse pulmonary interstitial emphysema mimicking emphysema. I mean, it looks identical, but I don't know what the heck that even means. So, I don't know. I mean, it does look very similar.
Exactly like the case.
Yeah.
Did they do alpha-1 testing on this person?
I don't, I looked at this yesterday. I didn't see any mention. It's just this very brief report. I just wish they had been, that they had some sort of, more detail or path on this. I mean, I don't buy this idea of persistent interstitial emphysema. That just doesn't make sense.
Travis, it looks like your case was exquisitely along the airways. This one looks like it's on the veins as well, which is a different
point. Yeah. I mean, in this patient, very similarly had airflow obstruction and COPD. So I don't know. Okay. I was just curious if anybody'd seen that. I'll keep it, maybe a couple years before we get an answer, but it was just such a crazy case.
All right. Are you done?
Yep. That's it for me. Thanks.
Got a few. I'm going to do them through PackSpin here. Let's see if I can get this to work. I have to share my screen. There we go.
I'm not seeing your screen yet.
Yeah,
there we go.
Making it. Yeah. Okay, well, this is relevant sort of Seth's case that he showed with the progression of fibrosis. So this is something we've seen before, but this is just such a nice example. So this is a patient who presented, patient carries a diagnosis of Sjogren's syndrome and presented initially with this CT scan a few years ago. And it's and this is pre-COVID. So this is just a nice organizing pneumonia pattern of injury. And you see a nice reversed halo up in that right upper lobe. There are a couple cysts in the lung, which I think are completely unrelated to the acute lung injury, but presumably part of the Sjogren. You see some there. And then and this was done on the outside. Then they showed up, they came back about 6 months later. I presume they got some steroids or something at that time. It's another outside study. And you can see that the nodules and consolidation have gone away, but now we have this lower lung predominant peribronchial ground glass opacity and sort of a thickening. It's got a sort of a subtle reticular abnormality, but it's got some nice subpleural sparing in some areas there. You can see right posteriorly there, and starting to get maybe a little bit of airway dilation. There's one of those cysts. And then this was the most recent scan, and I think this was one of ours. Yeah, I'll make it a little bigger here. Oh, there we go. So anyway, it sort of has evolved into this sort of an NSIP-like look here. So we've seen this before. It's been well described, and sort of the collagen in the airspace is sort of, as the lung injury heals and the epithelium regrows, sort of gets incorporated in there. And I think it's going to stabilize at this point because there's not an acute lung injury. But I did, it's not common to see that OP with Sjogren's. So I think they're concerned there's maybe an overlap with like myositis or something as well, which is not unheard of. But so if we biopsy, and I have one case, at least one, where we have two biopsies, one when the patient had OP and one when they had NSIP. So you can see two different patterns depending on time, but that can help as well. Just going back to the original scans, sort of along that conversation we were having, see where this started. So this was the initial presentation, and that's why I'd wonder about myositis, because it commonly will present with OP rather than showing up with fibrosis. Okay, what study is this one here? Okay, this is a great study here, and one of my colleagues made a good observation. It's just going to take a second to load the radiograph. So this patient had a esophageal cancer and underwent esophagectomy and a pull-through procedure. You can see there's the conduit there, and I don't know how well it's going to show up on here, but let's make it bigger. But one of my colleagues had noticed on this radiograph that there was some branching lucencies in the upper abdomen. The bowel is dilated here, which I think drew some attention to that. It looked kind of funny. So they were concerned about some ischemia in the bowel with some portal venous gas. So the patient went to CT. Let's see, that's the abdominal CT. I'll show you the chest CT first. So they did a chest CT to see what was going on with this in this chest, and there's the conduit there. But you'll notice there's this gas outlining the sort of in the wall of it. And there's so this is the native esophagus here, and this is an Ivor-Lewis esophagectomy. So it's an end-to-side anastomosis. And then you can see as I go down, there is pneumatosis in the conduit. There's your portal venous gas, which is quite pronounced. And then I'll show you the belly CT. They did that or maybe they did, I think they did the belly CT actually first. What's wrong way? Sorry, I'm using a trackpad I'm not familiar with. There we go. And as I go down, you'll see that there's the pneumatosis in the conduit, and then in the distal stomach, and even in some of the bowel here. But interestingly, there wasn't an obstruction of any real note, if I remember correctly. Just a sort of a functional one, but they managed the patient conservatively, and it did resolve. But it's interesting that it tracked all the way back up into the conduit, and the conduit itself was pretty happy. You can see there's a feeding jejunostomy, so it's unclear. You know, we've seen this in some of the lung transplants spontaneously, if it has to do with the enteral feeding or something like that. But I mean, you have to, of course, exclude something. But and I just saw another case of this, and I can't figure out if it's the same one because I had to go check my records, but this looks like a different case. So we may have had a second one with this in the conduit. I don't know if anyone's ever seen that before, but this is not, the conduit was not ischemic at all.
Jeff, what is the conduit made from?
It's stomach.
Okay.
Yeah, that's the typical one they would do, and occasionally they'll do small bowel or colon if the stomach is not usable. But yeah, this is just, they pull about 75% of the stomach into the chest. Because we've seen ischemic ones, and you'll see the staple line will fall apart, but not really pneumatosis. All right, and this last case is also kind of interesting. This is another ILD case where time is very important, and I guess it's possible there's two things going on, but I seriously doubt it. Let me make it a little bigger. So this was the scan that as presented. So this is the most recent scan. And if this patient came in for an ILD evaluation, I think most of us would go down the fibrotic NSIP route. You've got peribronchial predominant reticulation, ground glass, traction bronchiectasis. It's strikingly basal predominant. And you look in the upper lobes, and there's a little bit of air trapping, but not much. So I think it's a pretty good look for a fibrotic NSIP. But what's interesting is if you go back about 10 years, I should have gotten all the scans. This is how the patient initially presented. So with this thick peribronchial consolidation, but also all of these nodules. And if I go to this soft tissue windows here, let's see if there's a soft tissue one. Yeah, you see there's this pretty bulky mediastinal and hilar lymphadenopathy. So the patient actually got a transbronchial biopsy at that time. So this is like, I gotta say, like 10 years ago. And this was all non-caseating granulomata. And so a diagnosis of sarcoid was made. The patient had a CT I think it was about a year after that. And it more convincingly is gonna look like sarcoid at this point. I mean, there you go, there's classic perilymphatic nodules. I think everyone on this call would agree this is a good look for sarcoid. It's a little basal predominant, and then that stuff around the airways has definitely thickened up a little bit. So, and then a patient was treated for sarcoid with, I'm not sure exactly what the usual cocktails, probably some steroids. And then over time, this evolves to look like an NSIP pattern. So when they were referred to us with their initial imaging, we read this as favor connective tissue disease, NSIP, and then only recently have the old studies become available in the rest of the history. But it's kind of interesting, and I'm not 100% convinced this is all just sarcoid, or if this patient has two things, and that the biopsy missed the organizing pneumonia, and it was an evolving organizing lung injury, and then the patient developed sarcoid secondarily or independent of, and then went away and is left with this fibrotic NSIP. So I don't know. I mean, I've seen fibrotic sarcoid, but it's almost always strikingly peribronchial, upper lobe. I've never seen one look like this. Curious.
Yeah, I've never seen anything like that.
Did she have a connective tissue disease workup?
Yeah, I had the full ILD workup. Nothing ever came out other than the sarcoid diagnosis.
I've seen sarcoid evolve to a UIP pattern, and sometimes with exuberant honeycombing, no less. So I've not seen it go to an NSIP pattern like this, but I have seen it go to exuberant honeycombing. Has anybody else seen that?
Yeah, I've seen
Yes.
that. I've definitely seen that. I've just not seen the NSIP. I mean, that's so
Right.
strikingly NSIP. I mean, I just can't imagine they're related, but maybe they are.
Well, that's what I wonder. Was it two things? I mean, the fact that the fibrosis has stabilized. So if you had an untreated BTD, you would expect it to progress. So I wonder, but it was basal predominant to begin with. So maybe that's part of it. Had the bulky lymphadenopathy, or just happened to have two things at the same time, and they just ran their natural course. I don't know. I don't think it really matters at this point because both are patients been stable. But yeah, if they ever, I don't know if they'll ever go to transplant, but if they ever did, it would be very interesting to see these explants to see if there's.
So I'm sorry, Jeff. How old is this person?
Middle age. I don't know the exact age.
Okay.
Not a young person.
You know, I just view these interstitial pneumonias, these NSIP patterns and UIP patterns, as response to injury.
Mm-hmm.
And there are lots of ways to injure the lung. The classic presentation of IPF, you know, in the early descriptions when we were grappling with it in the 80s and 90s, was that you know, an older man would have a respiratory infection, and he would it would get better, and then he would start to get short of breath a few months later, and then it would turn out that he had pulmonary fibrosis that wasn't there a few months before. So in that sort of setting, it seemed that the infection had sort of maybe exposed some antigens, some basement membrane or something like that, and then there was this, the body starts responding to that injury, and then it has an out of control response that goes to pulmonary fibrosis. And then you talk about chronic hypersensitivity pneumonitis. That's an upper lung predominant disease, but then often you'll have the chronic phase, you'll have a basal predominant peripheral fibrosis that's NSIP or sometimes even UIP pattern. And so once again, you've injured the lung, you've exposed some antigens, and then you get this uncontrolled, response to injury that ends up causing a lot of lung fibrosis. And then the sarcoid cases that I've seen go to the exuberant honeycombing. Once again, you've injured the lung, you've exposed some antigens, and then you get this delayed, out of control, inappropriate response that leads to basal predominant fibrosis. So it doesn't surprise me that any way you injure the lung that you could trigger this response. So, response to injury.
Agree.
Now, just to expand on that, there was a very good lecture here in our grand rounds about 5 years ago. A rheumatologist was looking at rheumatoid arthritis as a disease of prematurely aged white blood cells, so that he basically said that your T lymphocytes are not properly regulated. So your T cell regulation is not working anymore. And he pointed out that rheumatoid arthritis has lots of similarities with TERT mutations that lead to lung fibrosis and so forth. That he really thought that there was a lot of evidence for aged, telomere, maybe limited white blood cell response. We know that rheumatoid arthritis leads to lung fibrosis. And we know that the people who get idiopathic pulmonary fibrosis are older men whose T cells may be running out of telomeres and stuff like that. So, once again, you have an unregulated response because you have these defective T cells and T cell regulation and stuff like that. So, I really think that, IPF may be a disease of injury followed by inappropriate response, and maybe it's because the T cells in those people are aged or defective because of, TERT limitations and things like that.
That's interesting, David, because there's, if you look at the literature on the so-called interstitial lung abnormalities, there's been a lot of studies associating those with the presence of other biomarkers of aging, like serum biomarkers, things I don't even remember what they're called, but somehow that may play.
Yeah, but I think it's right. It's probably the repeated injuries that are aging the lung with rheumatoid and even IPF. There's probably some unknown injury that just keeps injuring the pneumocytes and T cells and so on and so forth that leads them to lose some of the length in their telomeres. At least that's what I think, but who knows?
All right. Well, cases, guys. I think we will call it a day if that's okay.
Thanks, everyone.
All right. Talk to you next. Bye.